Hi, my name is Stacy Barden, and I'm here to talk about the evidence-based improvement project, Healthy Skin Project. Here we see the purpose of the Healthy Skin Project, and the purpose of the project proposal is to improve outcomes for pressure injuries in high-risk hospitalized patients due to an increase in reportable and non-reportable pressure injuries. There was an increased prevalence of HAPIs recently on a 40-bed ACE unit, which is acute care of the elderly, and they specifically focus on patients who are over 65. This led to the development of a Healthy Skin Project, which is a larger project. This is only one aspect of it, and the focus of the project is to improve the shift handoff communication of risk factors in older adults to prevent hospital-acquired pressure injuries through highly specialized communication tool. And in this project, we're looking at the Fulmer spices. The Healthy Skin Project was developed as a holistic view of patient skin. Our goal on the ACE unit is to keep patients at their highest level of functioning. And our goal with skin is to keep their skin at their baseline throughout their hospital stay. And the Healthy Skin Committee is an interdisciplinary team that came out of the Healthy Skin Project. And the team consists of RNs, CNAs, dietitians, physical therapists, case managers, transition and care nurse, and leadership. And their goal is to really develop processes and interventions to keep healthy skin healthy in our older population who are at risk for pressure injuries. And we really want to look at decreasing the prevalence of HAPIs or hospital-acquired pressure injuries. There's already a hospital wound team, which is a team of experts that assess and manage the daily wound consults hospital-wide, and they also perform quarterly skin audits. Unfortunately, they're not always readily available to be on the floors when there may be some question about skin in our patients. So we're looking at developing a medicine unit based wound team, and this team would consist of skin champions that serve as resource professionals to guide best practice and perform weekly skin audits. The goal of this project through the Healthy Skin Committee was to really look at what problems are we having when it comes to skin. And one problem that was identified from a roundtable discussion was the problem of omission of information during nursing handoff for patients with pressure injuries, as well as those who are at risk for pressure injuries. And when do these gaps in communication typically occur? Well, they usually occur when we're transferring patients or when you're change of shift. It also includes nurses to nursing assistants as well. And transition between units could be ED to the unit or ICU to the medicine unit. There also can be transitions between facilities as well. What kind of communication tools are valid and reliable for handoff? Well, in the past, there's been lots of studies to show that the SBAR tool is an effective tool, IPASS, and then we're looking at SPICES, which is really a geriatric risk assessment tool, but we want to utilize it as a communication tool. The background of this project is looking at the elder population during hospitalization. On the ACE unit, again, the criteria is 65 and older, although the average age is 85 and older. The elder population are the most vulnerable to complications in the hospital, including decrease in mobility or immobility due to illness. They may also have malnutrition or dehydration, which can affect their skin integrity and their wound healing properties. There's alterations in their mental status. This can impact all aspects of care, including mobility and nutrition. And patients who already have pressure injuries, skin tears, or wounds are already compromised, so this can be a challenge. Incontinence is not something we want to see in this population, but it can also put patients at risk for further skin breakdown. And the effects of HAPIs All those things that we talked about, immobility, malnutrition, dehydration, cognition, skin breakdown, and incontinence all lead to hospital-acquired pressure injuries. And the effects of hospital-acquired pressure injuries can lead to a cost of $11 billion in healthcare usage every year. Hospitals receive penalties if the hospital-acquired pressure injuries progress to a stage 3 or a stage 4 if they're reportable in nature. And there's also increased length of stay in these patients due to complications. They can have pain, immobility, and it can even lead to depression from isolation if the patient isn't able to get up. When we look at communication, we look at things such as omissions, and omissions really do impact care. So the result of omissions in communication, such as poor handoff, can lead to other challenges. There can be medication errors, there can be lack of consistency in care, there can be adverse events that happen. It definitely will increase their length of stay, and it can lead to poor transitions. The Joint Commission recognized this as a national patient safety goal, and they really look at improving and effective communication, which can ultimately lead to medical errors. And it's 2/3 of the sentinel events that we see in hospitals, and these are as a result of poor handoffs. And the Agency for Healthcare Research and Quality identifies that improving handoffs is a national priority. The ACE unit is based on the niche framework, which is Nurses Improving the Care of Health Stream Elders. And this focuses on a holistic way of caring for elderly patients. All aspects of the patients need to be assessed. It can't just be on one-size-fits-all care plans. They should be patient-centered. For example, if a patient has a respiratory issue, they may need to sit up to be able to breathe and improve their respiration status. If they have a pressure injury, this can impact their ability to offload. So that's something that we need to keep in mind. And it's an essential part of interdisciplinary care. All healthcare providers should be involved in minimizing further injury, and communication is a key to the success of that. So seeing the big picture isn't not always an easy task. It takes skill, it takes time, and sometimes this can be a barrier to prevention. That leads into our next slide about barriers. So barriers to quality handoff, we often see that the handoff can be very time consuming, especially if you have to go to the bedside and also engage the patient or the families in the conversations as well. There can be many interruptions or distractions, and miscommunication between the sender and the receiver can often happen, especially if the person doesn't ask questions. There's not always a standardized method, so if there's not one being utilized, then of course the methods can vary from nurse to nurse or nurse to nursing assistant. There may be low staffing on the unit, so that can impact the timing again if there's not enough nurses or if there's more patients than the nurse typically has to be able to effectively communicate. And also there can be misleading information. One of the nursing theories that we look at on the project for the Healthy Skin Committee is looking at Boykin and Schoenhofer's nurses as caring theory, because it focuses on humanness of persons and being whole in the moment. It really focuses on that patient-centered care that we're looking for. The nurse focuses on caring in the moment, moment to moment, with the patient and their participation as it relates to their personhood within the nurturing relationship. They identified the meta-paradigm of nursing as a discipline as well as a profession. And the patient is a recipient of care each moment, and the nurse responds to the needs of the patient, or the calls as they called it. They are whole beings, not identified as individual parts. And the situation or experiences are not always predictable or expected, but the nurse must be present in the moment with the patient to respond authentically to their needs. The context of environment is the influences of change in patterns, and health is a state of well-being. They felt that all persons deserve to be known, and the nurse must be able to commit to the care for the patient no matter what the circumstances are. And this really fits in line with the acute care of the elderly model. The PIO question for the Healthy Skin Project is, does the use of foam or spices communication tool at bedside handoff help decrease prevalence of hospital-acquired pressure injuries in high-risk elder patients? According to the Agency for Healthcare Research and Quality, knowing that a patient is at risk is only half the battle. It is essential that you act upon those risk factors and maintain the patient's safety. The focus should always be on prevention, not necessarily on intervention alone. And the use of multiple assessment tools helps to look at all aspects of care planning. The SPICES tool is a comprehensive assessment and communication tool that covers many different aspects of risk in elder populations. It can easily be used to prompt transfer of specific information as well as further discussion regarding those risk factors. It has been extensively studied for validity and reliability, and it can be used by any discipline on the care team, as well as to individualize care planning for that patient. And the goal really is patient-centered care to meet each individual needs. The acronym SPICES stands for sleep disturbance, problems with eating or feeding, incontinence, cognition, evidence of falls, and skin breakdown. And of course, all of these risk factors can contribute to the prevalence of pressure injuries in elder populations. Here we look at the review of the literature. 4 different studies talked about either pressure injury prevention programs or interventions, or the use of the SPICES tool. So the first one we looked at was a qualitative study, and their goal was to decrease the prevalence of hospital-acquired pressure injuries to 0, stage 3 and stage 4, over a 6-month period, and they were able to successfully do that with nursing involvement and really empowering the nurses to focus on techniques that would help prevent increase in prevalence of pressure injuries. The next study that we look at is a quantitative study, and this study focused on the use of the SPICES tool as an assessment tool in high-risk populations in an ICU unit. And their goal was to decrease rates of complications in high-risk patients. And not only did they do that, but they also decreased length of stay. This was a tool utilized by a multidisciplinary team, which speaks to the ability of it to be flexible and being utilized by different team members. Next, we look at a qualitative study that focused on pressure ulcer prevention care bundles, and this really was a multi-aspect prevention program that was to help prevent the prevalence of hospital-acquired pressure injuries on a medicine unit, and it focused on the nurse's perception of these interventions. And the outcome of that was that nurses did have more confidence in identifying risk factors, and they also had felt that it was workable and easy to incorporate into their daily tasks. And it also increased their communication on the unit, so that was important. And the last study that we looked at was validating the and assessing the reliability of the SPICES tool. And this was compared to other assessment tools and it was concluded that that the tool was very valid and reliable when looking at risk factors in high-risk elder populations and identifying um, possible adverse outcomes. The leadership meeting for the proposal of the project planning process and beginning implementation consisted of directors from the ACE Medicine Unit and Education Department, as well as the nurse manager on the ACE unit. We introduced the project proposal by discussing the problem and the background of the problem, and the goal of the project was also discussed. The PIO was presented, the sample population was discussed, as well as the time frame and the process of the implementation. The outcome measures were discussed and how the results of the project would be disseminated to stakeholders. And finally, the plans for proposed project sustainability were discussed as well. Here we see the details of the evidence-based improvement project. The project will take place on a medical ACE unit, which is a 40-bed unit. The adult population is 65 and older. The nurses and the nursing assistants work in a cohort on this unit, so they work 12-hour shift in tandem, and they have a 5-to-1 ratio. So the nurse and the nursing assistants report together at change of shift. The sample population will be the nurses and the nursing assistants on that unit. Only full-time and part-time employees will be included. The per diem and the float staff will not be included because it's too difficult to accomplish all the education. The SPICES tool will be utilized as the bedside shift handoff tool to help decrease the prevalence of hospital-acquired pressure injuries. And there will be a 30-minute educational session provided to all nurses and nursing assistants. The PowerPoint slides will detail the background, the importance, and the use of the tool. It will also include role-playing for better comprehension of the use of the tool. We will provide each of the staff members with a laminated card, and this will be used during bedside handoff for prompting, and also we'll give them some resource educational materials as well for retention. The time frame we're looking at is 30 days, and that includes the education and implementation of the project. Post-implementation, we're looking at outcome measures. The measures will be accomplished through observation of the shift handoff, and there will be post-implementation evaluation done, and it's a 3-part evaluation, and it's going to be given to all nurses and nursing assistants. And this will include demographics, it'll include their prior knowledge experience level with this population, understanding skin evaluation and interventions, and also their perception of the tool and whether it was something that they could use in practice. There will be data extraction from the Indian QI that keeps a running report of, it's a quarterly report, and it helps us evaluate the hospital-acquired reportable pressure injuries. And we'll also do a chart audit to evaluate the prevalence of hospital-acquired pressure injuries on our unit. To disseminate the outcomes, we're looking at roundtable discussions with leadership. We'll be meeting with them to discuss the outcomes. We'll have a PowerPoint presentation as well as a poster presentation. And at the system level, they have conferences where you can do PowerPoint presentations. So this is an opportunity to really get the information out to the masses. We also will send emails out of the project to all the stakeholders and discuss all the outcomes of that as well. During our discussion with the leadership team, some proposed project challenges were presented. The question of whether it's possible to get 100% of the staff educated is going to definitely be a challenge, and the amount of time that we expect to educate the nurses and nursing assistants. And we're trying to keep the time frame from education to implementation short so that it won't sacrifice retention of the material. Also, there is a possibility of challenges with staff from novice to expert based on their ability to utilize the tool effectively. We want to make sure that there's easy access for the staff of education and classes located near the unit, especially if they're going to be taking the class during work hours, which seems to be the most effective way to reach all the staff members. Access to the staff members at night versus days can be a challenge. Utilizing champions on the night shift will help to ensure that the night staff are educated as well and provide resource for them as well. And the last challenge proposed is the amount of time that it would take to implement this project during our regular work hours. The ability to sustain a project is always a challenge. So here we look at a few key items to help with sustainability. We look at promoting an environment of respect and responsibility. We look at interdisciplinary approaches, which are the key to successfully minimizing adverse outcomes. One man can't do it alone. It really takes a village. We also look at leadership involvement and how they should be able to promote an environment of teamwork, trust, and safety. And the use of adverse outcomes or causative factors should be used as a teaching opportunity, not necessarily pointing fingers. And this will really instill confidence and trust with the staff. And constant reinforcement and feedback is essential to prevent barriers to utilizing the tool effectively. Thank you so much for taking the time to listen to my presentation, and I look forward to hearing your feedback.